This eMultipleSclerosis review program is presented by DKB Med Radio.
OCT it's really an incredible tool, and there's more and more growing evidence supporting its use in MS. And because of that, it's being incorporated into more and more MS clinics, and it's being used as an important outcome measure in many clinical trials. It's fast, safe, it's reliable and repeatable, and it's been shown to correlate with many, many important outcomes of interest in MS.
Using the new biomarkers in clinical practice. Welcome to this edition of eMultipleSclerosis Review. New and emerging biomarkers. Can they fulfill a long-term unmet need in MS care? Can they monitor MS treatment efficacy? Indicate new lesion formation before MRI? Warn of near-future relapse? Predict impending relapse-related disabilities? How can they work in practice to help clinicians provide better care for their patients? To address some of these questions, we're joined today by Dr. Emily Schorr from the Department of Neurosciences at the University of California, San Diego. For our guest disclosures and additional CME information, please go to our website, emsreview.org, and select the Volume 5, Issue 12 link. I'm Bob Busker, DKB Med Editorial Director and Managing Editor of eMultipleSclerosis Review. Dr. Schorr, thank you for joining us today.
It's a pleasure to be here. Thank you for having me.
In your published journal review commentary, which is still available at emsreview.org, you discuss the evidence basis for the use of the MS biomarkers newly available. Today, let's take that information a step further and bring it into the clinic. Our first learning objective is describe the practical aspects of interpreting neurofilament light, or NFL, for progression or treatment response in people with MS. So start us out in the clinic, if you would please, Dr. Schorr, with our first patient scenario.
Absolutely. So the patient under our care today is Miss Marquis. She's a 35-year-old woman with multiple sclerosis on oral therapy with about 80% adherence. Her last MRI about 5 months ago was stable, though motion degraded. She's had her neurofilament light checked for the second time recently, and it is quite high. And it is even higher than it was the first time she had it checked about 6 months ago. She comes in today to discuss the meaning of this results and what the next steps are.
You explained neurofilament light, Doctor, in some detail in your commentary section in our last issue. Refresh us again, if you would, please. What is neurofilament light?
So neurofilament light is something measured in the blood that helps provide information about some aspects of MS. It's a protein that's found only in neurons and helps support their cell structure. So when neurons are damaged, their membrane breaks down and releases NFL. Speaking very loosely, it can be thought of a bit like a troponin for the brain. In prior years, we could only measure NFL in the CSF, but thanks to modern lab techniques, we can measure it now in the blood, which makes it a much more practical biomarker.
And is MS the only issue that drives neurofilament light levels?
No, it's not. So everyone has a certain amount of normal neuronal cell breakdown, and therefore NFL in the blood. Many things besides MS do increase the amount of NFL. Age is a top one. With normal aging, NFL levels go up. With a lower body mass index, NFL levels go up. And the kidneys clear NFL, so NFL may go up with renal disease. NFL is high in many other neurological conditions as well. But NFL has proven to be especially useful in MS, which is why it was granted approval as a breakthrough device. The FDA device program is designed to allow for faster approval for tools that facilitate care in areas of the greatest unmet need, and biomarkers in MS absolutely fit that category.
Dr. Schorr, in what ways has NFL been found to be useful in the management of multiple sclerosis?
So it's looking like NFL can be helpful in several different ways in MS, but we are still exploring its most optimal use. Its FDA approval is for use in relapsing MS patients to look at the risk of relapse within the near future. beyond the FDA approval, research suggests that NFL is really excellent MS in sort of three main categories. The first being that it correlates as an indicator of activity. It correlates well with relapses and with the new lesion formation MRI. The second is NFL seems to be good at predicting some aspects of MS, such as the risk of relapse in the near future or the risk of relapse-related disability. And then the third category where NFL seems like it's quite helpful for MS is in treatment efficacy monitoring. When people begin high efficacy therapy, NFL levels in some studies have dropped down to where they're really indistinguishable from healthy controls. And this is really exciting to have one biomarker that can look at so many different aspects of MS.
NFL, is it a useful tool for all forms of MS? As you said, the FDA has approved it for relapsing MS, but what about its utility in progressive disease?
So this is a really key point. NFL's relationship with progressive disease and progression independent of relapses is less clear. There's some conflicting results, and it's less certain, and that's part of why the approval was only for relapsing MS.
So the patient you brought us, her NFL's been rising for the past 6 months. How do you approach dealing with this finding?
So NFL, like essentially all biomarkers, is really most helpful as sort of one data point to add to the constellation of information that you have about a person. So we won't just hang our hat on just one result. I think in this case, I would start by confirming that the NFL result truly is high and is higher than we would expect for someone with her demographics and situation outside of the MS. One tool to help address this is an online calculator recently made available by a group of researchers out of Basel. It allows you to calculate the expected NFL in a healthy control of your patient's age and BMI. And so at least that gives you some framework to get a sense of given those factors, is this NFL, far outside the limits of what we'd expect. After considering that, assuming it really was truly elevated, next I would assess her holistically to look at any other factors, outside of MS that might be contributing to elevated NFL, something like renal disease that may be developed in the interim.
But if there's no other explanation, no kidney injury or other neurological issues, how would you explain to this patient what her high NFL finding means?
So in that case, I would explain to her that this high NFL does suggest that her MS is not as controlled as we would like, and that she is probably at risk, given her entire clinical situation, including the NFL, for accumulation of future disability. In terms of action steps, I think it would be valid, given the entire picture, to get an MRI perhaps a bit sooner than one would otherwise. And I would also want to discuss with her treatment options based on this, and based on the fact that she's reported, some issues with adherence regardless.
Well, her adherence, as you noted in her patient scenario, it's 80%. You can tell that it's not high enough, but how are you going to explain why increasing it is so important?
So I would discuss that in her case, given her clinical context and this concerning NFL results, that I'm concerned about her risk of impending relapse. And in addition to perhaps a bit more evaluation, I would absolutely want to talk with her about treatment options. I think it would be important to discuss with her if there were realistic ways that we could either improve the adherence of the medication that she's on currently, or if there are other stronger treatment options that might be a better fit for her.
This patient has been getting her neurofilament checked every 6 months. Is that considered an appropriate time frame?
Well, that is a a great and tough question. There really isn't consensus or strong data to guide about how often we should be checking NFL. I'm sure in some cases, checking it every 6 months or so will be appropriate, but it's going to be a learning curve for all of us.
Are there other biomarkers, doctor, either ones that are already in use or that are new and emerging, that NFL can be paired with?
So there are some emerging biomarkers still being studied that do appear to complement NFL. One of the most important complementary biomarkers is one called glial fibrillary acidic protein, or GFAP for simplicity. And studies show that when obtaining the two together, it can provide a bit of a more well-rounded prognostic picture than either alone. Some research groups are actually proposing that perhaps even equation combining a few biomarkers, including NFL and GFAP, can help determine whether someone is a progressive or relapsing patient, for example.
Thank you, Dr. Schorr. What we've talked about today bookends beautifully with the information you presented in last issue's written commentary. What I'd like to do now is review our discussion in light of our learning objective. Describe the practical aspects of interpreting neurofilament light, NFL, for progression or treatment response in people with MS. You presented a lot of information. What are the key points you'd want our learners to remember?
I think I'd say there's 5 key takeaway points. The first, NFL is a neuronal cytoskeletal protein that was recently FDA approved for use in relapsing MS patients. Number 2 would be that many things outside of MS can affect NFL, especially age, BMI, kidney function, and a whole range of other neurological conditions. The third point would be that NFL appears to be valuable as indicating activity in MS, in predicting relapses and relapse-related disability, and in monitoring treatment. But its relationship with progressive MS is less clear. The fourth point would be that emerging data suggests that other biomarkers in the works, such as GFAP perhaps, might be complementary with NFL for prognosticating an MS. And then the last point would be that, in terms of everyday practice, specific guidance about the logistics of actually using NFL to the individual in front of you is a bit limited, and we're still learning the basics, even something as simple as how often should we be checking NFL.
Thank you, Doctor. And we'll return with Dr. Emily Schorr from UC San Diego in just a moment. It really is a very simple question. Your CME, CEU credits, have you got all that you need? Because they're still available without charge from eMultipleSclerosis Review. It's the information you need to improve patient outcomes, combined with how that new information can be applied to clinical practice. eMultipleSclerosis Review delivers expert clinical advice and analysis. It's accredited for nurses as well as physicians, and all programs and credits are provided without charge. Find what you need at eMultipleSclerosisReview.org. Welcome back to this eMultiple Sclerosis Review program. We've been speaking with Dr. Emily Schorr from the Department of Neurosciences at the University of California, San Diego, about how to interpret NFL, the neurofilament light biomarkers, in the clinic. Let's turn now to our second learning objective. Describe the practical aspects of interpreting findings from OCT, optical coherence tomography, for progression or treatment response in people with MS. So if you would please, Dr. Schorr, take us back to the clinic with another patient scenario.
Absolutely. So Miss Edis is a 40-year-old woman with MS, diagnosed 10 years ago. Her last attack was of the cervical cord 4 years ago, and she had one bout of optic neuritis prior to that. She has preferred to remain off of DMT since she feels fine in between attacks and feels that she's recovered quite well from her prior two attacks. She's obtained annual OCT for the last several years, and her retinal layer thicknesses are below the first percentile for age-matched peers, and there's been a greater than expected rate of thinning noted on each scan. So she's coming in today to talk about what the best next steps are for her.
I think her reluctance to go on a DMT is understandable because she believes that her disability is not progressing. She's not feeling it, and she feels she's recovering well from her attacks. But she is showing, based on what we've been discussing, a number of risk factors that would indicate more severe or even progressive MS disability. Would you agree, Doctor?
Yes, definitely. So first, she has ongoing relapses, even if they're not very frequent, but she's off of treatment. So she may be accumulating some subclinical disability. She also has cervical cord involvement, which is another poor prognostic factor. And then lastly, now her OCT provides another important data point that really paints an overall concerning picture for Miss Edis.
So how can her OCT findings assist you?
So for interpreting her OCT, as with all newer biomarkers and even older biomarkers, first start off with verifying the validity of the results. So first, we would ensure that it really is thinned versus age-matched peers, which we know it is. And we would make sure that the OCT is quality, that it's not, significantly artifact degraded, or that there aren't major ophthalmological comorbidities that might be impacting her scans. Barring that, I would explain that the OCT is, additional evidence that she is at risk of worse neurological outcomes in the future, even when she isn't actively having frequent attacks.
Let's step back a moment, Doctor. I want to make sure everybody's on the same page here. Just what is OCT? Define it for us, if you would, please.
Yeah, so OCT it's really an incredible tool, and there's more and more growing evidence supporting its use in MS. And because of that, it's being incorporated into more and more MS clinics, and it's being used as an important outcome measure in many clinical trials. As my mentors have described it, OCT can be thought of somewhat like a quantitative ophthalmoscope. And it's really a very appealing biomarker. It's fast, safe, it's reliable and repeatable, and it's been shown to correlate with many, many important outcomes of interest in MS.
In your published journal review commentaries, Doctor, you mentioned retinal layers that can reflect global CNS processes. Talk to us about that, if you would, please.
Yes. So there's two retinal layers that have arguably the most extensive data behind their use. One is the retinal nerve fiber layer, or the RNFL, which should not be mistaken for NFL, which we just discussed, and the ganglion cell layer. So for example, the ganglion cell layer has been shown to correlate quite well with brain atrophy, and brain atrophy is a fairly established marker of neurodegeneration. So this is a really exciting, promising way to get a better look at progressive MS, where there is such a critically unmet need for biomarkers. There's also emerging research, as discussed in the most recent commentary, that other retinal layers may also be able to predict a more aggressive MS course.
What can you tell us, Doctor, about how OCT actually works?
So OCT can be thought of sort of like a light-based ultrasound, where retinal layers are measured to the degree of the micron based on how light reflects back from the retina. And this all just takes seconds to obtain, which is pretty amazing. OCT technology has really come a long way in the last couple of decades.
Question, Dr. Schorr. When a patient's retina starts to show rapid thinning, as it does with the patient you brought us, will her retina stay that way, or can anything improve it?
So it's an important question. Unfortunately, There's no known way to, grow back retinal layers as seen on OCT. But what we do hope to do is stabilize and slow the rate of atrophy. And that is what some of our best treatments can do.
So that kind of leaves initiating a high efficacy DMT in this patient. Is that what you would advise?
Yeah, most likely, yes. Though, of course, drug selection would depend on many other factors. I think in this case, the OCT would be something that I could show to and discuss with the patient as sort of, quantifiable evidence of irreversible damage.
The patient you described, she's 40 years of age. Would you have the same concerns and give her the same advice about her OCT findings if she was, say, 70 years old?
So, in a nutshell, I would probably be less concerned about her OCT changes. But of course, I would still be concerned about the relapse that happened just a few years ago.
Why is that?
So, a recent study clarified that in older MS patients, so that's roughly, older than mid-50s or so, the thinning seen on OCT over time is actually largely driven by aging and not actually by MS.
Interesting. What about for patients who have had optic neuritis or ophthalmologic comorbidities? Are OCT measurements still valid?
This is a really important question. Yes, there are expected changes in OCT that we expect to see around the time of an optic neuritis event. So for the first several days or weeks, the RNFL will actually appear to thicken because it's swollen edematous. And then over time, over weeks and months, the RNFL will reveal that it is atrophying after an optic neuritis event. And the GCIPL will begin atrophying very shortly, days after optic neuritis. Most studies that include people who've had a history of optic neuritis will account for that through various methods, but there is expected post-optic neuritis atrophy seen on OCT. And then in terms of ophthalmologic comorbidities, those can absolutely affect OCT results. But for many of them, there's expected patterns that we know to look for that can help us interpret the OCT of this person despite their comorbidity.
Final question on this case, doctor. This patient that you brought us, what treatment did she receive and how did she respond?
Yes, so convinced by the OCT data, even though she feels fine off of DMT in between relapses, she agrees to start high efficacy therapy.
And the results?
And a year later, she's relapse free. Her OCT thinning has normalized to an expected rate, and she's doing very well.
Excellent.
Yes, and the lesson is that biomarkers are not just for researchers and clinicians. The additional information that biomarkers provide can really help empower patients to make decisions in their own care.
Thank you for sharing your knowledge about OCT with us, Dr. Schorr. Let's review our discussion now through the lens of our learning objective. Describe the practical aspects of interpreting optical coherence tomography, OCT, for progression or treatment response in people with MS. What are the key things our learners need to know?
Yeah, so some key takeaway points about OCT would be the first, that OCT captures discrete retinal layers and growing data supports it as a practical biomarker for use in MS. Different retinal layers, such as the RNFL or GCIPL, have been shown to predict MS-related disability, to correspond with the type of treatment that they're getting, to correlate with brain atrophy, future MS activity, and other variables of interest. As with all biomarkers, adjusting and accounting for important patient factors, such as age, is really critical when interpreting OCT. Another key takeaway point would be that the rate of atrophy related to MS appears to be more important in younger patients with MS, whereas in older patients with MS, the atrophy rate may be driven more by normal aging.
Dr. Emily Schorr from the Department of Neurosciences at the University of California, San Diego, thank you for sharing your expertise with us in this eMultiple Sclerosis Review program.
Thank you so much for having me. It's a pleasure to get to highlight two exciting biomarkers that might really improve the care we provide for our MS patients.
For eMultiple Sclerosis Review, I'm Bob Busker.